Hey there, future orthopedic leaders. Welcome back to the Deep Dive. We're here to cut through the noise, get straight to the high-yield knowledge you really need. Today, we're doing a crucial deep dive, one that's tailored specifically for you as you're gearing up for those big postgraduate exit exams, the FRCS or equivalent fellowship exams. We're tackling total hip replacement, THR. Specifically, we're focusing on complications, failure, and revision. It's fundamental stuff, but pretty complex too. And this entire deep dive draws its essential insights from the OrthoMate Simple Notes. You can find those over on mokyingren.sg. Just so you know, these great notes were put together by Dr. Mok Ying Ren. He's a sports surgeon over at National University Hospital in Singapore, and he completed his FRCS back in 2022. So our mission today is really to distill the critical points, the things that will give you an edge.
Exactly. We'll look at not just what happens when a THR fails, but more importantly, why it matters, both for your clinical decisions and, of course, for those exams. We'll guide you through the kind of diagnostic thinking and the management pathways, so hopefully you walk away with a much clearer, more connected understanding of these challenges.
Okay, sounds good. Let's kick things off with something foundational, something that often trips people up a bit. The difference between polyethylene cup creep and wear. They sound similar, right? But what's the actual clinical significance?
Yeah, it's a really good starting point because they represent quite different processes. So creep is actually a normal thing.
Normal. Okay.
Yeah, think of it as the expected molding, maybe deformation is a better word, of the poly cup under typical sustained physiological load. You'll usually see this thinning superomedially. Basically, the plastic is just sort of settling into the main weight-bearing zone. It's just an inherent property of the material, part of how it functions.
Right, just settling in.
Oh, exactly. Now, wear, in contrast, signals something abnormal. Abnormal loading, maybe increased friction. This shows up as actual loss of polyethylene material. You usually see this thinning on the superolateral side, so it's not just conforming, it's a destructive process.
Yeah.
And that can lead to problems down the line, osteolysis, loosening. The key takeaway is creep is expected, wear is definitely problematic.
That's a really critical distinction, especially when you're looking at x-rays.
Okay.
So for any resident, understanding why a THR fails is, well, it's paramount. What's the most common reason for revision, according to the big registries, like the UK National Joint Registry?
Right. Well, according to the UK NJR, aseptic loosening is the most frequent reason overall for THR revision. But, and here's the really crucial part, especially for exams and for your clinical thinking, the timing of the failure changes what the most likely culprit is.
Okay, how so?
Well, within that first year after the THR, instability is actually the most common reason for revision.
Instability, really, before loosening.
Yeah. Followed by fracture, then infection, and then aseptic loosening comes into play. But shift beyond that 1 year mark, and aseptic loosening takes over again as the dominant factor. After a year, it's aseptic loosening, then pain, then infection, and then instability drops down the list. That shift, based purely on the timeline, is such a high-yield point for your initial differential diagnosis.
That time-based differential is incredibly valuable, yeah. Okay, so let's put this into practice. A patient walks into your clinic, painful THR. How do you approach them? What's your immediate sort of triple assessment?
Right. So when that patient comes in, your immediate priority is what we often call a triple assessment. It's about quickly ruling out the really critical issues. First up, and you absolutely cannot stress this enough, you must rule out infection. That's non-negotiable, demands immediate attention.
Always a number one.
Always. Second, you need to consider and actively exclude extrinsic causes of pain. Remember, pain can refer from the spine, maybe other pelvic sources, and it can really mimic hip problems.
Good point. Easy to forget.
Yeah. And finally, number 3, evaluate for those intrinsic features of loosening, which, let's face it, is often our first thought with a painful joint replacement.
Okay, so for loosening specifically, what are the classic features we're looking for?
Classic features often include startup pain, that pain that's worse after resting and then improves a bit with activity. If you're thinking about the femoral component, look for pain specifically with internal or external rotation suggests micromotion at the stem. For acetabular loosening, groin pain, especially with a resisted straight leg raise, that's a key indicator.
Got it. And beyond that initial assessment, what other specific details are you really trying to pull out from their history in the physical exam?
Okay, history-wise, you're digging deeper. Any signs of sepsis fever? Chills? How long have the symptoms been going on? Was there ever a pain-free period after their first surgery? That's quite important. Characterize the pain carefully. Is it that startup type? Is it mainly groin or buttock pain suggesting the acetabulum? Or is it more thigh pain pointing towards the stem?
Location matters.
Definitely. Don't forget their functional level, any comorbidities. And crucially, try if you can to get details of the original surgery. Operative notes, any post-op wound issues, antibiotic suppression history, and always keep that differential open. Could it be referred spinal pain causing thigh symptoms?
Right. And on the physical exam.
On exam, first, inspect the wound, any sinus, redness, signs of infection. Observe their gait, look for a Trendelenburg sign, check for any leg length discrepancy, LLD. Then a full range of motion assessment, obviously, and a careful neurovascular check are vital. Cover all the bases.
Okay, meticulous history and exam done. What investigations are you ordering next to confirm suspicions or rule things out?
Right, investigations. To rule out infection, routine bloods are essential. Your full blood count, FBC, C-reactive protein, CRP, and erythrocyte sedimentation rate, THR. These are your basic inflammatory markers.
That's standard stuff.
Pretty standard, yeah. Imaging starts with standard AP and lateral x-rays. Often you'll want long leg films as well, just to assess overall alignment. Then a CT scan can give you much more detail on the bone stock, the extent of any loosening. Really crucial for surgical planning.
And if infection is still high on the list?
If infection remains a real concern based on the history, the exam, maybe those bloods are up, then a joint aspiration is absolutely indicated. You need cell count, differential, gram stain, and cultures.
Okay. When you're scrutinizing those x-rays, what specific features for both the acetabular and femoral components should we be actively looking for and, describing in our notes or reports?
Good question. For the acetabular component, you're really assessing the integrity of that medial wall. Use the acetabular teardrop and Kohler's line, the ilioischial line, as your guides. Look specifically for any ischiolysis that points to posterior column problems. Note any vertical migration of the cup. How much has it moved? 2 centimeters. More than 2 centimeters. That changes the Poprowski grade.
Right, the classification.
Exactly. And for the femoral component, you're evaluating the extent of lysis, both metaphyseal and diaphyseal, often using the Gruen zones. Look for those reactive lines, maybe signs of cement mantle fracture if it's cemented.
Okay, let's pivot slightly to a specific and often quite distressing complication. Sciatic nerve palsy after a THR. What typically causes this?
Yeah, it's a tough one. Interestingly, about half of these cases, maybe 50%, actually have an unknown cause, which is, well, humbling.
Really? Half?
Yeah. But for the known causes, it could be compression from a hematoma, maybe direct injury during surgery from retraction, misplaced screws, or sometimes significant limb lengthening, usually considered over about 5 centimeters.
And is there a particular part of the sciatic nerve that's usually affected?
Yes, the peroneal division is typically affected in about 80% of cases. It's the same pattern you often see in hip dislocations, too.
Why the peroneal division specifically?
Well, it's generally thought to be because of its anatomical course. It's more superficial, has fewer fascial attachments, may be less mobile, making it more vulnerable to stretch or compression injuries around the hip.
Makes sense. So how do we investigate and manage this acutely? And what's the general prognosis?
Investigation usually involves an MRI first, specifically looking for a hematoma that might be compressing the nerve. Early nerve conduction studies, NCS and EMG, are also crucial to actually assess the extent of the nerve damage and establish a baseline.
And the acute management?
Acutely, the first thing is simple. Immediately flex the knee, maybe using pillows, just to reduce tension on the nerve. If that MRI does show a significant hematoma, then surgical evacuation is often required fairly urgently for decompression. If the MRI is clear, no hematoma, then you typically monitor with serial NCS over time. As for outcomes, they're unfortunately quite varied. Roughly, it breaks down into thirds. About 1/3 achieve full recovery, 1/3 get partial recovery, and sadly, about 1/3 show no significant improvement.
Right. Quite variable outcomes then. Okay, moving on. Let's talk about bilateral THR. Doing both hips. Single stage versus two-stage. Is there a clear consensus on which is better?
Currently there isn't really a clear consensus. It's still debated. Meta-analyses that have compared single-stage versus two-stage procedures, they haven't shown significant differences in the major complications, things like mortality, PE, major cardiovascular events, or even infection rates.
Oh, that's interesting. I might have expected single stage to be riskier.
Yeah, intuitively you might think that, but the data doesn't strongly support it for major complications. Now, single stage does offer certain advantages, things like a potentially lower risk of DVT overall, shorter total operative time across the board, and obviously reduced total hospital stay. Plus, you get the benefits of just one anesthesia event one recovery period, and potentially lower overall costs.
But there must be downsides, too.
Absolutely. The drawbacks include typically higher blood transfusion requirements for the single event, a higher concentration of physiological risk into that one longer operation, and obviously it is a longer single surgery. So really, each approach has distinct pros and cons. The choice honestly depends heavily on individual patient factors, their overall health, their comorbidities, their preferences. It really necessitates careful shared decision-making.
Okay. Robotics and navigation, they're becoming increasingly relevant in orthopedics, including THR. How can we systematically compare these different systems?
That's a great way to think about it systematically. We can compare them across, say, 3 key parameters. It helps structure your understanding. First, by their imaging requirements. Some systems are image-dependent, meaning they need a preoperative CT or maybe an MRI to build a 3D model of the patient's anatomy.
Okay, so pre-op scan needed.
Right. Others are imageless. These rely on intraoperative calibration, basically registering anatomical landmarks during the surgery itself. Second, you can compare them by their level of automation. You have passive systems, which essentially just provide visual guidance on a screen, no physical interaction. Then there are semi-active systems. These offer haptic feedback. They might guide the surgeon's hand or limit movement within predefined boundaries.
Like guardrails?
Kinda, yeah. And finally, you have active systems, which are fully automatic, performing certain steps robotically, with the surgeon primarily supervising. And the third parameter is the platform. Is it a closed platform, meaning it's designed to work only with specific implants from one company? Or is it an open platform, which offers more versatility, allowing use with implants from multiple manufacturers?
That's a really useful framework. Imaging, automation, platform. Okay, let's dive into cemented hip failure now. What are the classic modes of cemented stem failure? Particularly Gruen's modes, they seem essential to know.
Oh, absolutely. Gruen's classification is fundamental for interpreting X-rays of cemented stems. So mode 1 is pistoning. That's basically vertical motion of the stem. And it can be either 1A, where the stem itself moves within the cement mantle, indicating a poor stem-cement bond. Or it can be 1B, where the entire cement mantle and stem complex moves together within the bone, signaling a complete loss of fixation to the bone itself.
Big difference there.
Huge difference. Mode 2 is medial mid-stem pivot. This implies loosening both proximally and distally, with the mid-stem acting like a pivot point. Mode 3 is calcar pivot. Here there's distal toggling or loosening, but the proximal part seems stable, so only distal loosening. And finally, mode 4 is bending cantilever. This often manifests clinically as implant breakage, usually at the neck, due to fatigue failure under bending stress. Understanding these modes helps you pinpoint exactly how the construct is failing.
That gives a really clear picture of the failure patterns.
Yeah.
But why does the cement mantle itself actually break? What's the mechanism?
It's primarily an issue of fatigue failure. Think about the cyclic stresses that cement mantle endures over years and years of walking. Eventually, those stresses can exceed the fatigue endurance limit of both the stem-cement interface and, importantly, the cement material itself. Repeated loading leads to microcracks, these propagate, and eventually you get macroscopic failure.
Okay, so if fatigue is the main enemy here, how do we prevent this? What are the keys to getting a durable, long-lasting cement mantle?
Prevention really hinges on optimal cementing technique. It comes down to a few critical factors. First, good alignment. Specifically, you want to avoid varus positioning of the stem.
Why VAR specifically?
Because varus alignment tends to create thin cement mantles in high-stress areas, particularly Gruen zone 7, which is proximal medial, and zone 3, distal lateral. Thin mantles are weak points. Second, you need to ensure no cement voids. This is achieved through techniques like vacuum mixing, which removes air bubbles, and pressurization during insertion. These are hallmarks of modern third-generation cementing.
Right, getting rid of weak spots.
Exactly. And thirdly, achieving a good, consistent cement mantle thickness, generally aiming for greater than 2 millimeters all around. Using centralizers to keep the stem positioned correctly within the canal is key here, another vital third-generation technique.
But speaking of cement mantles, I remember seeing something in the notes about the French paradox. It sounded like it offered a slightly different perspective on optimal thickness. Can you unpack that?
Ah, yes, the French paradox. It's a really fascinating counterpoint, actually. It refers to observations, primarily from French surgeons initially, where certain polished stem designs, often used with thinner cement mantles, actually demonstrated surprisingly good long-term results.
Thinner mantles doing well. That seems counterintuitive to the 2-millimeter rule.
It does, doesn't it? The theory, in part, was that these polished stems were designed to subside slightly within the mantle, achieving a stable equilibrium through controlled micromotion rather than relying solely on a rigid, thick mantle for fixation. It really challenges the simplistic, thicker is always better idea, and highlights that the interaction between stem design, surface finish, cement properties, and technique is much more nuanced than we perhaps initially thought. It's a great example of how our understanding evolves in orthopedics.
Very interesting nuance.
You know?
Okay, let's switch gears to cementless stems. How do we assess if a cementless stem is stable or loose, especially when you're planning for extraction in a revision case?
Right. For cementless stems, we often turn to the classification described by Glassman and Eng back in 1992. It categorizes fixation modes and really helps predict how difficult extraction might be. So, if you have stable bony ingrowth or osseointegration, you'll typically see no subsidence, maybe evidence of spot welding, that's endosteal hypertrophy, where bone has grown right onto the porous coating. You might also see proximal stress shielding, indicating good distal fixation, and importantly, an absence of reactive lines.
And what does that mean for extraction?
It means that stem is very well fixed. It usually cannot be removed by simple disimpaction. You'll almost certainly need an extended trochanteric osteotomy, ETO, and specialized tools like burrs to divide the bone-implant interface. Then you have stable fibrous fixation. This is characterized by no progressive subsidence. It might have settled initially, but then stabilized within the first year or so. You might see parallel reactive lines along the stem indicating a fibrous membrane, and often minimal proximal atrophy. These can sometimes be removed without an ETO, but not always easily.
Okay, and the third type?
The third is unstable fixation. This is what you typically think of as loose. You'll see signs like progressive subsidence over time, maybe evidence of toggle or movement on stress views. You might see hypertrophy of bone at the collar or stem tip, often pedestal formation that's bone forming a sort of shelf under the distal tip, and sometimes canal enlargement around the stem. These unstable stems are generally much easier to remove, often without needing an ETO.
Got it. So just to summarize quickly, what are the common radiographic signs we look for loosening, comparing uncemented and cemented stems?
Sure. For uncemented stems, the key signs are progressive subsidence, that pedestal formation at the tip, progressive or widening radiolucent lines around the implant, or sometimes outright implant fracture. For cemented stems, you're looking for fracture of the cement mantle itself, any change in the implant's position relative to the bone or cement, and progressive radiolucent lines either at the cement-bone interface or the cement implant interface.
Perfect. Now let's get into the real nitty-gritty, revision surgery itself. Classifying the amount of bone loss you're dealing with seems absolutely foundational when you're planning these complex cases, right?
Oh, absolutely critical. You cannot plan a revision properly without accurately assessing the bone loss. For the acetabulum, we primarily use the Poprosky classification. It relies on assessing the integrity using those key radiographic landmarks we mentioned: Kohler's line, the roof, the acetabular teardrop, and looking for any lysis, especially esophageal lysis posteriorly.
Can you quickly run through the types?
Sure. Type 1 is minimal bone loss. The acetabulum is essentially an undistorted hemisphere. Relatively straightforward. Type 2 involves some distortion and initial migration, but crucially less than 2 centimeters, and the columns are still intact and supportive. This gets subdivided into 2A, supromedial migration, 2B, superlateral, and 2C, medial migration or protrusio, but not breaching Kohler's line.
Okay, columns intact is key for type 2.
Exactly. Then you get to type 3. Here you have more significant migration, usually greater than 2 centimeters, and the columns are distorted and generally not supportive. Type 3A is typically described as up and out migration. You might have moderate ischiolysis, but the medial teardrop is often intact, and Kohler's line, iliobuccal, and the iliopubic line are usually intact. Type 3B is the most severe category, often described as up and in migration. Critically, this often signifies pelvic discontinuity. You'll see a broken Kohler's line, extensive ischial osteolysis, loss of the teardrop structure. There's a very high risk of an occult fracture running through both the anterior and posterior columns, even if not immediately obvious on plain x-rays.
Pelvic discontinuity, that sounds challenging.
Extremely challenging, requires very specific reconstruction techniques.
And for the femoral side, how do we classify bone loss there? Is it also the Poprosky system?
Yes, we use the Poprosky classification for the femur as well. It focuses on the amount and location of remaining bone stock, particularly in the metaphysis and diaphysis, which dictates where you can get fixation. Type 1, minimal bone loss. You still have good metaphyseal and diaphyseal bone.
You've lost significant metaphyseal bone, but the diaphysis, the shaft, is still largely intact and supportive.
Now you're losing diaphyseal bone too, but you still have more than 4 centimeters of intact diaphyseal bone distal to the isthmus available for fixation.
Similar diaphyseal loss, but now you have less than 4 centimeters of diaphyseal support remaining. Getting distal fixation becomes much more challenging.
Represents massive bone loss, essentially no reliable diaphyseal support left.
Okay, so these classifications, both acetabular and femoral, they directly guide your surgical strategy and implant choice, right?
Absolutely. They are the roadmap for planning the reconstruction.
All right, this sounds incredibly complex. Let's take a typical scenario. A THR revision needed for significant osteolysis, maybe even a broken implant component. How do you approach such a complex revision case? What's the overarching strategy?
Okay, yeah, this is a complex revision scenario. The key goals are always twofold. Achieve stable implant fixation and ensure the hip itself is stable postoperatively. We often think about it in phases. Preoperative preparations are absolutely paramount. This isn't just templating. It involves a thorough anesthetic review for comorbidities. Detailed templating, yes, but often supplemented with a CT scan to really quantify that bone stock accurately. You need to anticipate difficulties. Have standby extraction tools readily available, specialized systems like the Moreland set, maybe trephines for drilling into broken stems. For cemented stems, things like the Oscar ultrasound cement removal system can be invaluable, or you might even consider a cement-on-cement revision if the existing mantle is intact and well fixed.
And for cementless?
For cementless, you need microsagittal saw blades, thin, flexible osteotomes, maybe an acetabular explant tool. Most importantly, have your standby implants ready based on that Poprosky classification you determined preoperatively. You need an algorithm in your head, or even written down. For the acetabulum, this might mean planning for structural grafts, maybe metal augments for a type 3B, possibly even a custom triflange cage cup construct. For the femur, the core principle is always to bypass the most distal defect by at least 2 cortical diameters with your new stem.
That pre-op planning sounds intense. What about intraoperatively? Is there a mnemonic or framework you use?
Yeah, a helpful mnemonic often used is EERRR. Exposure, extraction, examine, reconstruct, replace, rehabilitation.
Okay, walk us through that. EE.
Right, exposure. You need adequate exposure. Often this means an extensile posterior approach, maybe releasing the gluteus maximus insertion, possibly the psoas. Crucially, you need to be prepared to perform an extended trochanteric osteotomy, ETO, if you can't get the stem out otherwise, although Eng's work suggested it might not always be needed for unstable fixation.
If you do an ETO. If you do it, know the principles. Careful longitudinal cut, usually 12-15 centimeters down from the GT, a transverse cut leaving enough posterior bone, like 20/3 diameter, and always place prophylactic circlage wires about 1 centimeter below the planned osteotomy tip to prevent the fracture propagating down the shaft. Next, E is extraction. This is often the hardest part. The absolute primary goal here is preventing proximal femur fracture. For cemented stems, use the tool's Oscar system, maybe screws into the polyliner, flexible osteotomes. Cement on cement is an option sometimes. For cementless stems, remember Eng's finding. If it's truly unstable, Poprosky unstable, it often comes out relatively easily, sometimes without an ETO. If it feels stable after removing granulation tissue and giving it a few firm taps with an extraction device, it probably is stable, and you'll likely need that ETO or at least careful division of the bone implant interface using burrs and thin osteotomes distally first, then working proximally.
Okay, EE done, then RRR.
Right. Once the implants are out, carefully examine the remaining bone stock. Confirm your pre-op assessment or adjust your plan if needed. Address those bone defects. Maybe use impaction bone grafting, maybe structural allografts, maybe metal augments.
Implant the new components based on your plan, guided by the Poprosky classification and the reconstruction performed.
Finally, plan the post-op rehab. Often this involves gentle toe-touch weight bearing initially, with close follow-up x-rays.
That's a great framework. After that challenging extraction, let's revisit the implant options specifically. For the cup and the stem, how do the choices scale with the Poprosky types?
Okay, for the acetabular cup. Type 1, minimal loss. Often you just revise to a standard hemispherical cup, maybe slightly larger than the original. Miller's textbook suggests around 85% of cases can be managed this way. Type 2A, 2B, 2C, columns intact, some distortion. Here you might need metal augments to fill peripheral defects or perhaps structural grafts like a bulk femoral head allograft combined with a hemispherical cup. For 2C, protrusio, sometimes a cup-on-cup technique is used, where a smaller cup acts as a medial augment. Type 3A, up and out, columns compromised. Now you need more robust solutions. Options include highly porous metal cups, like trabecular metal, maybe oblong cups for better contact, jumbo cups, 60 millimeters, or specific column augments with screw fixation. Bone grafting strategies, like using iliac crest graft with mesh and then cementing a cup, are also possibilities. Type 3B, pelvic discontinuity. This typically requires bridging the defect. The gold standard is often considered a triflange cage cup construct. These have flanges extending onto the ilium, ischium, and pubis, creating a stable scaffold for structural morselized bone graft with the cemented cup inside the cage.
Wow, the acetabular options really escalate. What about the femoral stem?
For the femur, the guiding principle remains: bypass the most distal defect by at least 2 cortical diameters. Type 1 or 2, metaphyseal loss, intact diaphysis. Often managed with an extensively porous coated stem to get diaphyseal fixation. For type 2, with significant calcar loss, an extensively coated calcar replacement stem might be used. Type 3A, diaphyseal loss, 4 centimeter support. Here you typically need a long, modular tapered stem designed for distal fixation in the remaining diaphysis. Fluted, tapered designs are common. Type 3B, diaphyseal loss, 4 centimeter support. This is very challenging. Impaction bone grafting, IBG, using morselized allograft packed into the deficient canal, followed by cementing a polished tapered stem, is a common technique. Sometimes this is combined with a cortical strut allograft plate for extra support. Type 4, no diaphyseal support. Extreme cases. Options might include IBG with a cemented stem, sometimes a proximal femoral replacement megaprosthesis, or perhaps an allograft prosthetic composite APC, where a segment of cadaveric femur containing the implant is used.
That really highlights how critical that pre-op classification is for having the right implants available. What about persistent instability after a revision THR? That must be incredibly frustrating. What strategies can we use then?
Recurrent instability after revision is a major headache. There are several strategies you can employ, often in combination. First, revisit the basics. Optimize component positioning. Restore correct leg length, offset, and version as anatomically as possible. Increase the head-to-neck ratio. Using a larger femoral head can significantly improve stability by increasing the distance the head needs to travel before dislocating. Increase the head-to-neck ratio. Use a constrained liner, sometimes called a captive cup. This has a locking mechanism to physically prevent the head from coming out. The downside is it transfers dislocation forces to the implant bone interfaces, potentially risking loosening. Increase the head-to-neck ratio. Convert to a bipolar hemiarthroplasty. Essentially replaces the acetabular component with a large head that moves within a polyliner, which itself moves within the native or revised acetabulum. Increase the head-to-neck ratio. Utilize a dual mobility bearing. This involves a small head articulating within a larger polyethylene liner, which in turn articulates within the metal acetabular shell. Offers increased range of motion before impingement and greater jump distance. Each option has its place, depending on the patient and the reason for instability.
Lots of options to consider there. Okay, finally, let's tackle that really challenging scenario. Ceramic catastrophic failure. You mentioned it's brittle. How exactly does it fail so dramatically?
Right, ceramic is a brittle material, unlike ductile metals. Its failure mechanism involves crack initiation and propagation. Under stress, maybe from impact or impingement, microscopic cracks can form. These tiny cracks can then grow, often slowly at first, until they reach a critical size. Once they hit that critical size, they propagate extremely rapidly, almost instantaneously through the structure. This leads to that sudden, catastrophic fragmentation. It happens abruptly, right after the material's yield point is exceeded, which is very different from how ductile materials deform and tear more gradually.
That sounds, well, explosive almost. What investigations do we need, and how do we approach managing this complex revision?
A CT scan is usually the primary investigation. It helps visualize the extent of fragmentation, which can be extensive, and assess any associated bone damage or implant loosening. And management is definitely a complex revision. That EEERR mnemonic applies again, but with some very specific, critical considerations for ceramic failure.
What are those specific points?
Preoperative preparations are even more crucial. You absolutely must have specialized explant equipment ready, but also a full second implant set available, because you have to assume all components might need changing. The revision should ideally be done as soon as feasible to minimize further damage from abrasive ceramic fragments grinding on metal tapers, and the patient must be strictly non-weight bearing in the interim.
Okay, intra-op.
Intra-op. Exposure needs to be excellent, usually extensile posterior. Extraction requires meticulous care. You need profuse joint lavage, washing out liters and liters, trying to remove every single visible ceramic fragment. This is critical because those fragments are incredibly hard and abrasive. Extensive synovectomy is also needed to remove fragments embedded in the soft tissues. Critically, you generally must replace both components, head and liner, possibly stem and cup, even if only one component appears visibly fractured. Unseen microcracks or damage to the mating surface of the other component can lead to early failure if it's left in situ. If the stem's Morse taper is visually scratched or damaged by fragments, you must revise the stem, no question.
And if the cup seems okay but the liner's shattered?
If the middle cup shell itself seems undamaged and is well fixed, and revising it would cause significant bone loss or be hazardous, some might consider only revising the liner. But you have to be very careful inspecting that shell. If there's any sign of damage, or if the original positioning was poor, leading to impingement and the fracture, then replacing the whole cup is safer.
Okay, EERRR.
Examine meticulously for any damage, especially to metal tapers. Reconstruct any bone defects caused by the fracture event or extraction. Replace. Now, the bearing choice here is actually quite controversial.
How so?
Because even with the most thorough lavage, microscopic ceramic particles will inevitably remain. Some authors argue you should replace with a new ceramic head again, because ceramic on ceramic is very hard and resists third-body wear from those residual particles. Another option often considered is XLPE, highly cross-linked polyethylene, on ceramic. However, using XLPE on a metal head is generally not recommended in this specific situation, precisely because those residual hard ceramic particles can severely scratch the metal head and cause aggressive third-body wear of the polyethylene liner.
That's a critical point about bearing choice.
Absolutely. And finally, rehabilitation follows a careful protocol, often protected weight bearing initially.
Okay, let's just take a quick pause there. Just a reminder for everyone listening, this deep dive is based on the incredibly valuable Ortho-Made Simple Notes, which you can find over on mokyingren.sg. We'll be right back to wrap things up. And we're back. That brings us to the end of our deep dive today into THR complications, failure, and revision. Wow, we've certainly covered a lot of ground. Everything from those subtle differences between polyethylene creep and wear, through the really critical steps of patient assessment and investigation, all the way to the complexities of revision strategies for bone loss, instability, and even that specific challenge of ceramic catastrophic failure. It's a huge topic.
It really is. And hopefully we've highlighted that understanding these principles, the classifications like Laprosky, the management algorithms, it isn't just about memorizing facts for an exam. It's fundamentally about providing the best, safest, and most effective care for your patients facing these difficult situations. Every detail we've discussed today, from identifying startup pain to choosing the right revision implant based on bone loss, can genuinely be the key to a successful outcome. And again, this information is distilled from the Ortho-Made Simple Notes available at mokyingren.sg. Truly a fantastic resource for your ongoing study and preparation.
Absolutely. So keep connecting those dots, keep asking those why questions behind the classifications and techniques, and just keep building that expertise. You are all well on your way to becoming truly outstanding orthopedic surgeons, and you'll make a massive difference in your patients' lives.
Definitely. And as you continue on your journey, studying hard and preparing for your exams, perhaps remember this little bit of encouragement from Proverbs chapter 11, verse 26. The people curse him who holds back grain, but a blessing is on the head of him who sells it. May your knowledge always be shared generously for the benefit of others, and may you be truly blessed in all your endeavors. Until next time, keep diving deep.